thank again our sponsors, and particularly the California Healthcare Foundation, our presenting sponsor, our platinum sponsors, who you can see here on the slide, Zoma, Cigna, and Sage. Thank you so much. And our gold sponsor, Hope Lab, who hosted our Mom Tech lunch yesterday, we're calling it. So thank you, Hope Lab, and our supporters, Mommy Hannah Institute, and Maven. And on that note, I would like to invite one of our gold sponsors to the stage and invite Stuart Hart to the stage. She's the head of patient advocacy at Sage Therapeutics. Thank you again for all of your support over the years and for sponsoring the forum again this year.
I am Marjorie Stewart Hart. I'm the head of patient advocacy at Sage Therapeutics. I'm actually here with several of my amazing colleagues, Brian, Lily, Zach, and Danielle. So if you see them or if you guys are out there, give a wave. I'm really so proud of the people that I work with at Sage and the passion that they have for this work. This is actually my third forum. I shared last year how nervous I was the first time because I really knew nothing about this. I was about a month into my job at Sage. And Sage was actually in the process of developing the very first therapy that was indicated for postpartum depression, which is actually available for moms. This was my first introduction into the PMEDS community, and so I can't think of a better place where I could have started. And importantly, this was just my first step into this journey that so many of you have been on for so long, into really understanding the importance and criticality of maternal mental health. And I'm really grateful and honored that you've invited me on this journey with you. Sage is honored to be on this journey with you, and we're looking forward to continuing long into the future. My team and I are so grateful that this happens at the beginning of the year, because what this has turned into for us is the place where we get our fuel and our motivation, because spending these 2 days with you reminds us and grounds us in how important the work that we are doing really is. So we're grateful for that, and we bring this motivation and our excitement from this meeting back to all of our colleagues at Sage, and they're so appreciative of all the work that you're doing as well. You know, this year's theme could not be a more appropriate or powerful call to action. We can do more gives us the time to honor how far we have come, and that's due to all of you in this room and so many others. But it also inspires us because we know that there's so much more than we can do. Sage is really so proud to stand with 2020 Mom and all of you, and we remain committed to making sure that moms can get the treatment they need with the urgency they deserve. So thank you so much for allowing us to be a part of this, and we're looking forward to a wonderful day. And now it's my distinct honor to introduce you to the moderator of our next panel to discuss peer support for all of us. Rebecca Alderfer is a senior program consultant leading the area of perinatal mental health at Zoma Foundation. Rebecca began her career at the White House Office of Management and Budget in Washington, D.C., where she shaped policy and funding direction for a portfolio of multi-billion-dollar international aid programs. This work progressed to leadership roles in innovative programs with the State Department and at the Global Fund to Fight AIDS, Tuberculosis, and Malaria, managing staff and relationships with international colleagues in a dedicated effort to prevent and treat infectious diseases. Later, Rebecca joined the Pew Charitable Trust, where she served as a strategic advisor for new philanthropic investments. Relocating to Colorado, she joined a Denver-based health policy institute called the Colorado Health Institute, focused on informing policymakers and leaders on health and healthcare issues in Colorado. Rebecca is also a partner with Social Venture Partners in Boulder County. She is a Boulder County Leadership Fellow alum. She earned a Bachelor of Science degree in economics from Iowa State University and a master's degree in public policy from the Humphrey School of Public Affairs at the University of Minnesota. So she sounds like just such a slacker. My goodness. So please join me in welcoming her to actually get this panel going. Thank you.
I have never had anyone read my whole bio, and that is, it's a little, wow. So thank you very much, and thank you to everyone who's here this morning. As they read, I'm here representing the Zoma Foundation. I'm a senior program consultant for them. The Zoma Foundation is based in Denver, Colorado, and we've been working on changing the way perinatal mental health is addressed and prioritized in Colorado for over a decade now. And I have to give a shout out. Last year I was watching this forum from Denver Health with a whole bunch of colleagues, and right now they should all be gathered at Clayton Early Learning in Denver, Colorado. Hello, everyone. We have an absolutely amazing, dedicated, huge group of collaborators and stakeholders in Colorado that are all focused on perinatal mental health, and they're doing amazing work, and it's an honor that I get to be with them all the time. So the Zoma Foundation is focused on all expectant and new mothers are screened for perinatal mood and anxiety disorders and have access to critical information sources and support from appropriately trained professionals. That's our North Star. That's where we're headed in Colorado. And what about our involvement in peer support? Why am I moderating this panel today? So I was approached by Dr. Sona Demijan at the University of Colorado School of Psychology, who's done a lot of work around behavioral activation across the globe, primarily in India, and was really focused on how we bring the tools of behavioral activation and the idea of using community members to help support the mental health process and wellness across our state. So, as you heard, having had experience working with global infectious diseases, I understood that using all of your assets in supporting health, whether it's providing antiretrovirals or bed nets for malaria across Africa, or using community members and laypersons in Colorado to help support the mental health of our population with folks that look like you and speak like you and really know what you've gone through. So we started on this journey, and now we're going to share and have an amazing panel of folks that are going to share what peer support is really about, what it looks like in action, and we hope you have lots and lots of questions for us about how this model works and what are some of the things that maybe we still need to even learn. So let's dig in. We heard a little bit about peer support yesterday in the parity panel. It came up. We heard about it again in the tech lunch. So I'm going to give you just a few seconds of what is peer support so that we all kind of have a grounding going into this conversation. So a couple of organizations have outlined for you what peer support is. So Mental Health America talks about this being an evidence-based practice, that it's really focused on sharing of similar experiences, and they have seen improved outcomes and quality of life, reducing hospitalizations and the cost of care. SAMHSA also has outlined what they see as peer support, and it really encompasses a range of activities, which we'll talk about later. Again, the core pieces are having shared similar experiences. It's about empowerment, connection, and hope, really giving people the opportunity to hope. If you go on SAMHSA, the SAMHSA HRSA Center for Integrated Health Solutions page, there's a whole document about peer support specialists. If you go on NCSL, the National Conference of State Legislatures, there's a whole fact sheet about peer support that can give you a lot of depth around what this looks like in states and what it looks like from the federal government's perspective. So is peer support recognized by the federal government? Yes, it is. And it has been for a while now. So HRSA, the Health Resources and Services Administration, SAMHSA, which is the Substance Abuse and Mental Health Services Administration, and CMS, the Centers for Medicaid Services, all recognize peer support. CMS has recognized it since 2007. So what does it mean to be certified? What is a certified peer specialist? Certification means that you've had training, that you've had training that gives you certain sets of competencies so that you are an actually informed and helpful peer, and that you have retained that information. So there's usually a test that goes along with it as well to know that you actually have those competencies and can recall them as needed. Every state has a specialized certification process except for California. And Joy tells me that that's coming. So So potentially every state in the union will have one soon, but it looks different across states. Some states have certified peer specialist programs that focus on a broad set of mental health issues. Some have them specifically for substance abuse issues, and some have it across kind of a whole spectrum of different mental health issues. And the really big question is, what about payment, right? How do you support these models and sustain them? And we're going to dig into some of that during the panel as well. There's at least 36 states, and the numbers vary depending on which fact sheet you look at, but it's somewhere in the high 30s. States offer reimbursement, usually through their Medicaid program, although some states have grant-funded programs that are run through different departments than maybe their state Medicaid agency. Again, it looks a little different depending on where you sit. And then what do peer specialists do? They do a lot of things, and the folks that are going to be talking to us on the panel will get much more granular around what it looks like on the ground. But there's really kind of 4 pieces to this, as outlined by the federal government and other standards. It's around emotional support, right? There's the empathy and the connection and the knowing that you know piece of peer support specialists. It's informational. There's resources and education provided. It's instrumental in providing support, helping people identify what it is they need in that moment, and then figuring out how they're going to get to that support. And then it's affiliational as well. So connections to community resources, support groups, helping share events or ways that you can get out and be a part of some of the other things that might help you along your journey. And is perinatal mental health ripe for certified peer specialists? I would posit that the answer is yes, and I think our panel would probably say the same. But we'll have a good conversation about that, I think, and here's why. We talked a lot about provider shortages yesterday and how hard it is to find the kinds of support that have been trained in perinatal mental health. We also talked about stigma, and so if you have the opportunity to sit with someone who looks like you and talks like you and has been through the kinds of things that you're experiencing, it's a huge boost. Enhancing the cultural competency in care and having that opportunity to draw from different communities. Increasing access in community. We talked about access to care and what that looks like, and it's getting outside of the 4 walls of a clinic or a hospital. It's getting out into people's homes, it's getting to the parks, it's getting to the libraries. Cost-effective expansion of services and supports. Peers are a fairly low-cost workforce, and again, we'll get into some of the payment and the reimbursement, and then providing meaningful career pathways for mothers and others that have experienced this and wished that they could do something for others now in this field and be a part of the system that's helping to support mothers. So today, we're going to hear about a few different programs. So first, we're going to invite Lisa up to the stage, and I'll tell you who Lisa is in a minute, to talk about a study that 2020 Mom did around piloting maternal mental health training for peer support specialists. And then we'll talk about the Women's Health Innovations Program in Arizona that's really doing it. They're on the ground setting up and standing up a program in peer support specialists. I'm going to give you just a brief overview of ALMA, which is the program in Colorado that we've been working with a lot. And sadly, the 2 leaders of that program in Colorado could not be here today, but we'll share just a few snippets. And then Sister Circles is a peer support model that is also ramping up in California. And then we're also going to hear from a peer herself and her experience and life story that led her to become a peer. So I hope you're excited about this panel, and we'll get started. So I'm going to ask Lisa Melchior, I should have asked you how to say it, who is a PhD and president of the Measurement Group, LLC, and it's a California-based group that works on behavioral health and social science, and she was the lead on the maternal mental health peer support training study. Lisa, please come on up.
So as Rebecca mentioned, I'm Dr. Lisa Melchior. I'm president of the measurement group. We're here in Los Angeles, and we work with behavioral health programs to evaluate their programs and disseminate what we learn from that. I want to thank Michelle Quezada, who's here in the audience, who helped a lot with this study, and also Jackie Gelfand previously contributed as well on our team. So I'm a research psychologist by training. And this project, I was so excited when Joy approached us about helping to do this pilot study because it seemed like just such a really great idea and a very unique opportunity. The pilot training and the evaluation were supported in part by a grant from the New Venture Fund, the Hope and Grace Project. I'm going to give you a very, very brief overview of just what we were looking at in the study and to help set the stage for the other panelists. And the report that is the basis of the presentation, I believe, is in your meeting app, and if it's not now, it will be by the end of the conference. So this is just a basic overview of the peer support specialist training model that we were looking at. It was a two-component training. So as Rebecca discussed, there's actually pretty strong evidence base for peer support as a modality. And so there are established trainings that have worked with people in various behavioral health capacities to help teach soft skills, things about working in a service provider environment that are not specialized to any particular condition. And that's the peer support specialist component. The participants went through a 2-week training that was provided by Recovery International. And then the maternal mental health component was specific to content related to maternal mental health, working in maternal mental health settings, and that was a 2-day follow-on training. Because this was a pilot test, the numbers were very small, and this was really just an exploratory study to find out how people just get some feedback about the training, and then later on, if they had used any of the information. Again, very small numbers. It wasn't really possible to do an experimental design, but we really just wanted to get some feedback about the training to see if and how it was used to provide maternal mental health peer support in community service settings. So this is some data from the feedback we got immediately at the end of the peer support training, and the feedback was, very, very strong. People said they really got a lot out of it, and if we looked at just some, pre and post retrospective ratings, the participants did say they increased their knowledge, both generally about peer support and specific to maternal mental health issues, increased their confidence to go do work in the field, and specifically, again, for maternal mental health issues. They showed promise for really advancing this field through specialized peer support training. People found it useful. We have examples of how it impacted maternal mental health peer support, impacted people not only in their work, but in their personal lives as well. Some challenges were identified. You'll hear, I believe, from Michelle and other panelists about the supports that are involved in having peers on staff doing maternal mental health services, and that clearly there was a need for ongoing support. The other thing is it's wonderful that some agencies do have a clear professional path, but it's not always clear in a lot of different settings, so that came up as well. Some of the things we learned about doing maternal mental health peer support training within the broader context of peer support training was that this really is a specialized population, and that the trainings need to address that as well. Joy has mentioned that her original hypothesis in doing this training was that maternal mental health peers are a unique population with unique needs, and that was definitely supported by the pilot test. So some of the recommendations that are outlined in the report have to do with having opportunities for resources and networking beyond the trainings, having gender-specific trainings because this really is a gender-specific issue, integrating the maternal mental health content within the broader peer support issues, and having mechanisms for support and guidance post-training. Now, I believe Joy is going to come up and kind of set the stage for the next part. Thank you.
We will go ahead and walk through them, and just want to thank again the measurement group for their leadership in conducting this study, and also for those who participated in it, particularly WHI, Michelle and her team, who were boots on the ground administering the training program in 2 states, Arizona and in Texas for us, even though they're just based in Arizona. So thank you for that project management role that you played as well. Again, the hypothesis for the study was that these existing training programs that are in place in every state should be utilized and could be utilized for maternal mental health, but that there might need to be some modifications to those programs, just like there have been modifications for programs for veterans, for example. And so next steps, we know now that this is the case, and so what are we going to do? How are we going to roll out a program that's unique to maternal mental health? And we have been invited by Cigna to apply for a grant to start work here in California, but eventually expand that work outside of California to allow this model to be proliferated. And that means that we're going to be creating a in-depth training. We did a nice maternal mental health training with Michelle's help at WHI. We want to create a online training program that can be downloaded and refreshed annually for peers who go through this certification program. We're also looking at ways that we can help employers like clinics and hospitals learn how to find certified peers to address maternal mental health needs, and then support those employers by connecting them through an online collaboration platform so that those employers can talk about things that they're struggling with, employing peers, and also remind them how they can bill for these services through Medicaid in their states. So with that, I'm going to turn it back to Rebecca, and we're going to introduce the other panelists.
So we've already met Lisa from the measurement group. Next, we have Michelle Lacey, who is the executive director of the Women's Health Innovations of Arizona, which is a licensed outpatient treatment center and nonprofit specializing in maternal mental health care. We have Hassana, who is the founder and CEO of Hassana 9 Exchange. Hassana is a peer support specialist and also a survivor of pregnancy loss, and is going to share some of her story and background. And then we also have Sonia Young Adam, who is the CEO of the California Black Women's Health Project. So give a round of applause for these panelists, and we'll get started. So I'm just going to ask, we kind of broke this up into 3 sections. The first section is models of peer support. Let's learn a little bit about the models. And then we'll talk about the experience of being a peer, and then we're going to just open it up to our questions that I have some planned for you all. And then we'll hopefully hear a lot from the audience and folks that are watching across the country. So I'm going to start with Michelle. Michelle, can you share how the peers that were trained in the 2020 Mom pilot are being utilized at your organization, and about the implementation? And you can also just tell us a little bit about all that you do and the work of the center.
So we, at Women's Health Innovation of Arizona, we are truly service-oriented. Many of us in our organization came from the substance use treatment field where we used peers. And because our organization specializes in maternal mental health, it made a lot of sense to us to utilize peers to help bridge the gap. And so the peers that we have are going bedside at 2 hospitals in our community to provide support and education to those moms who are identified at risk. And honestly, we work really closely with the hospital staff, so the risk could be pretty loose. It could be really tense in the room, and that can be an indicator to get someone to come over bedside. Due to a contract and a grant that we have through Dignity Healthcare, we are able to have a peer on site at one of the hospitals twice a week. And then she follows up 2 to 3 weeks later to just see where things are at and connect her to services. We also have our peers in a community agency in downtown Phoenix who provides bilingual services, peer support services, a group, and parenting. And what we're finding there is that we have grandparents that are help raising their grandchildren. They did not have their perinatal mood and anxiety disorder treated. And so now it's reemerging as in their role of grandparent. And they're able to share it with our peer. And we just had some feedback from one of our moms there that said this program has allowed her to have a freedom that she's never had before, because she can talk about the pain and the struggle that she went through without the shame. And this is really exciting for us, because this is why we do what we do. We have a strong belief in that we need moms to get services. Our peers, though, are part of our therapeutic team, and we will provide extra training and supervision 2 hours a week with our entire team. And then we have individual supervision with our peers. Our peers are going in home and bridging the gap. So I know we kind of talked about sharing a story, but we had a mom who was really struggling with a pretty significant trauma history, and there was a big stigma against counseling or seeking out mental health care, but she was okay with our peer coming into her home. And through the relationship that she was able to develop with that mom, we were able to get her into services, and now she's doing trauma work. So that's how powerful our peers are and how we're utilizing them. And I don't even know if I answered your question, but I'm pretty passionate about this topic, so.
You did. Next we're going to hear from Sonia. And Sonia, tell us more about Sister Circles, and also tell us about your organization and some of your background. We want to hear about Sister Circles, we want to hear about peers, and we also want to hear about the communities that you work in.
I'm very happy to be here, and I certainly appreciate the invitation and the opportunity to come and to speak with you about the work that we do at the California Black Women's Health Project. And I have to say this as a sort of a preface to my comments going forward, that I am not always accustomed to speaking in audiences that are not as diverse, because the work that I do is very, very directly centered and focused unapologetically on Black women and girls and families in the state of California. So, thank you. So I do want to acknowledge that last night, for those of you who were at the dinner at the Standard, that there was one lady who did speak very passionately about the issue of equity. And she asked that we hold, I don't know if she's here in the room this morning. Yes. I wanted to run up and give you a hug, but I wasn't sure if you'd say, okay, that's too much. We're on. Okay, so I wanted to just raise that because the discussion around the issues of equity and the issues of acknowledging where there are gross disparities sort of across the board in the areas that affect Black and African American women, our general health, our mental health, and our perinatal mental health, and our health in general. So I would normally spend time sort of unpacking a history of issues and challenges that, begin and end with racism, structural inequities that exist in systems, that exist in our society and in our institutions. And I would talk about that, and I would bring that knowledge to the forefront in an audience that might be more diverse in this. But I want to respect that not every audience is working closely with Black and African American communities or marginalized communities. Not every person engaged in their work spends time in this area. And so to give you all of that history and to spend time doing that, it might not be helpful. If you're in North Washington State and there is a population that, is one, thank you, we had this conversation yesterday. A population that, might be 1%. This is not necessarily an issue that might be at the forefront of your life every day. So I'm going to just say that. And then also, when we begin to have conversations that go deep and talk about disparities and the reasons why our work is so important, generally there are more people that look like me in the room. And then when we unpack these things, they're very deep, they're very emotional, they cut deep and hard. And then, there wouldn't be enough in this room to help me repack it so that I could go home and face my family and have the rest of my evening without spending it in tears. So I see my dear sister, Miss Winona Valentine, with I Dream of Health Equity and Racial Equity in the room, and I appreciate that she's here and a few others, and we do this work together in LA County and around the state of California. So I appreciate that you're here, and I know when I'm done I could go and get a hug from Winona because she'll understand exactly what I'm talking about. So that being said, I just want to say that the Black Women's Health Project has designed and implemented a sister circle model that we use throughout all of our programming areas. So that includes areas like even violence prevention and even around, obviously, mental health and around, maternal health and all of the issues that really impact Black women. It's a sister circle model that is rooted, it's nationally recognized, it's rooted in evidence, and we utilize this practice as an engagement model for training Black women and increasing the community's capacity for service and healing and coming together and filling the gaps where the current systems are not adequate or fully resourced to provide us with the care that we need. So for mental health in particular, our program is called Sisters Mentally Mobilized. It's one of the most exciting things that we've developed. It is supported by the California Department of Public Health's California Reducing Disparities Project. And we are part of the African American cohort, but there are 5 population groups, including API, Latin America, Asian and Pacific Islanders, API, Native American, and LGBTQ. And so the racial and ethnic disparities that are faced around mental health have been cited by the state of California. $60 million has been invested in this project. It is intensely evaluated by Loyola Marymount University, and we are in a pilot project. We are in year 3 of a 5-year project. And so we have had a chance to, we were operating these sister circles and we utilized them as an engagement model and to train women to be advocates and to be navigators and to stand in the gap for themselves as they face and deal with the challenges of their own mental health, but also for their family and their friends in the community. We train Black women who are hairstylists to recognize signs and symptoms of depression, anxiety, and mental health disorders in their clients. Because in our community, we spend a great deal of time with our hairdresser. and if you're not African American, you might not know that. But the relationship, that's one that can last 20 years or more, okay? And your hairdresser has heard it all, felt it all in you, recognizes even issues and challenges as they exist in your hair and in your skin. Yes. So this peer model that we've designed is set up to create a safe space for women to come together, to share, to deal, to heal, to love, to cry, to anything that needs to happen in these spaces. We have a set of standards that we utilize where we use intensely cultural elements that set the atmosphere. Everything, I tell people, everything from the smell in the room is attended to. From what you see, what you hear, the utilization of music, the utilization of a combination of things that are deeply rooted in African and African American culture. Those are the elements that we use. And then we bring in licensed mental health professionals to provide the clinical training, the systems training. We bring in policy people to talk about what happens at the legislative level, where they can deal with local, regional, and statewide policy issues and address systems gaps. We also talk about the healthcare system and the provider side and where there are strengths and weaknesses in that area of care. We talk about the lack of diversity in the health professions, and that is a major challenge. So we support and encourage through pipeline efforts Black women who are trying to expand their capacity and their knowledge and their professional skills to specifically target our population. We create databases and we refine them constantly so that they're fresh and up to date, because sometimes you can find a person to provide a level of care and sometimes you cannot. Now, from a perinatal standpoint, some people in the room who I've talked to know that we are launching into refining our curriculum to address perinatal health. And we are going to pilot a training in the Inland Empire. I don't know if that means anything if you're out of state. Riverside and San Bernardino counties. There you are, the IE in the house. So we are going to pilot a program there. Right now, we do not have funding to support that. We are sort of pulling it together, with pieces, and we have a professional, Dr. Saida Prepad. I'm not sure if some of you may know her, and she is going to act as the facilitator for this training. And we are going to launch this training because obviously the areas of mental health that impact Black women, we could go on all day. The psychosocial stressors, the issues in our community, the challenges of what happens when we do face a mental health issue. Calling 911 is, that's an issue all by itself. Training the women to be there for each other, training them to build coping mechanisms within themselves, and then training them to recognize signs and symptoms and be ready to navigate and to mobilize in the community around these issues. So I could go into great detail about the model. One of the challenges that I do have with peer training and the peer model that the California is planning to implement, and hopefully it'll pass through the legislation, SB 10, is that, and you mentioned it in one of your slides, is that, and SAMHSA I think includes this, that the peer would have lived experience and a diagnosed mental health disorder. That is the challenge for us, because in our lives, for most of us, when we even write grants and say, does your board or your staff have lived experience? I'm like, we are the lived experience. It's impossible to be Black in America and not have the lived experience. It just is. It is. And so, but to have a diagnosed disorder, that is where, when we've written to the assembly person, and, it's like we challenge that piece of it, because if you live in a household, if you're dealing with it, I'm dealing with an issue right now, and having to help my family where we have not been able to find services through a Kaiser system, which I could go on all day on that one. And so, if you can be a peer and you can train and you can be trained and certified without having the diagnosed disorder. And that is where I would challenge, sort of the existing parameters.
That's a really great point. A really great point, and we should pick up on that more. Absolutely. It's hard to follow, Sonia, but I am going to take just a minute to talk about the other program that we were hoping would be able to join us today and just couldn't for a variety of reasons. It's called the ALMA program, and it's being piloted and launched in Colorado, and ALMA means soul in Spanish. It's a program that is focused not solely for Latinas and the Latin cultures, but it is being piloted in 2 different Latina communities. But it's also being piloted in Kaiser, actually, in Colorado. Sorry, we'll talk about that later. And so the ALMA program is a certified peer support specialist training. It's online, so the training happens online, and then there are coaches at the School of Psychology in Colorado, in Boulder, that are doing the coaching and the supervision and the reflective supervision with all of these peers. And then they're the anchor back to being able to help when there are issues or things that the peers need to discuss, and doing the bi-weekly, I think, follow-up calls with peers to see how things are going. Right now, the pilot is happening in 3 communities. One is a very rural community out in the Roaring Fork Valley of Colorado that is a Latina community or a Latino community of folks that may or may not be recent immigrants to the United States and work in agriculture and service industries in that part of the state. There's also a pilot happening in Denver in a community, a Latino community in Aurora, and it's being anchored by both the mental health center in Aurora and then also with an FQHC that these are the ways that the peers are being introduced to folks and working in the community. And then it's also being piloted in Kaiser in Colorado, and they're doing the research on sort of pre and post intervention and in more of a randomly controlled trial sort of environment. There's a 2-pager about Alma in your app, and you can learn more, and then we can always direct you to the folks that are working on that program as well. So we've heard about 3 different models. We've heard about the Women's Innovation Center in Arizona. We've talked about sister circles, and now I think it's important to hear from a peer herself. So Hassana, can you talk a little bit about the experience that you had that led you to become a peer, and then also the training that you went through to be a peer support specialist, and some of your experience in working with other women?
Well, first of all, I'm honored to be here, and I'm glad for all of you that are interested. Well, I was determined at 17 to have my first baby when I was 21, which I did accomplish that. But when I was 7 months pregnant, they told me that my baby was in distress, and they were ready to induce labor on me. So at the end of the ultrasound, the tech said, "That's enough of that." That was hurting the baby ears anyway. So then I started to cry before they took me down. I wanted to call my mom. But then when they took me to my room, and after I had spoke on the phone, called my mom, this doctor came and said, "We don't know what's the matter with you, but you are a high-risk patient, and you need to come in twice, every 2 weeks to be seen, and you can get dressed and go home." So I thought, if I had not started to cry or wanted to call my mom, they would have taken me straight down and induced labor on me. So when I got out of there, I never went back until I went in labor. And I didn't accept anything that they had to offer me because I was afraid. And so I say that the fear of what they had to offer was greater than my pain. So I had an undisturbed birth, and my daughter ended up just fine. 8 years later, I married, and within 14 years, I've had I was wounded by non-traumatizing miscarriages. So I am wounded, and that's what causes me to be who I am today. And I go by Hassana 9 Exchange, Hassana 9, but my company name is Hassana 9 Exchange because I'm always delighted to reach out to others and to do anything to help anyone. During that time, I've had all those miscarriages. I am an interior decorator, and I do custom window treatments and upholstery, and I have taken that knowledge and I use it holistically to help others that are wounded, through maybe colors that can help motivate them, or adding some of it in their home along with the other healing tools. So yeah, that's what I do.
Can you tell us a little bit about your training? What kind of training did you have?
Oh yeah. So that caused me to, to become a peer, to be able just to reach out. And a lot of the training that I had, where I had it at, it was more so dealing with like substance abuse and things of that nature, but I just used it pertaining to my area and how I can reach out to those that I connect with. So it's all the, the healing tools and the coping strategies and the unpacking, but I add that extra seasoning in there as far as being an interior decorator and, whatever can help this person come through. And then I am very open, and I have all types of stories, all kind, and, from different angles. So it's very easy for me to drop in, especially if someone's really going through trauma. I can really relate to them very well, and we can work it out. I can feel them. And I'm letting them know, if I haven't been there, I've been pretty close or past that, So, yeah, the training was good, but it dealt with a lot of the substance abuse, but still it's the same concept that can be taken and used for whatever, the problem may be.
Do you remember where was your training or who administered it?
It was with Share in Culver City. Yeah, it's a organization there, nonprofit organization there, and they deal with like housing, substance abuse, this and that, and they, help people.
Not letting you off the hook yet. I'm going to keep you talking.
That's okay.
So, is there a story of a woman that you've worked with as a peer that you could share kind of what that relationship was like?
It was really nice. I had flew to North Carolina to visit a family, and their daughter had just had a baby when we got there. So I was still there, when she came home. And she was having some issues, and one of them was, it was hard for her. She was complaining about feeding her baby, and, the baby, she couldn't get the baby to nurse. She really wanted to nurse the baby, but she didn't want to give it a bottle, but she was complaining that she could just, she was having some issues. So one of them, I was like, well, why don't you help him? And she was like, what do you mean? And I was like, well, first of all, your breast is so engorged. It's hard for him to latch on. So why don't you kind of like, get some of the milk out and, make the nipple stand out so that he can latch on. And then she was like, please don't leave. She wanted me to stay. But so, then I have others that are, just going through some trauma. I had a woman that had a baby and she hadn't touched him in 6 months. It's just she was having some issues and she just hadn't touched him. It was the other family members, and so, I talked to her, and, was trying to, connect with her. But I didn't live where she lived. Actually, this was in a whole nother place, and I couldn't stay. But, yeah, so it's definitely a need, and sometime to go and stay there a while, like stay with the person, depending on the severity of their problem.
Thank you, Hassana, and we're going to ask more questions in a little bit.
Okay.
So I have some questions for the panel, and then we're going to turn it over to all of you, and hopefully we'll ask some of the hard ones. So some of the things that have come up when talking about peer support is what are some of the risks around peer support, the risks and rewards, because there's probably both, right, in developing and operating a perinatal peer support program. And then how do you mitigate those risks? And when I say risks, some of the things that have come up are how do you make sure that a peer knows when somebody may need a higher level of support? You know, how do you make sure that you have the lifeline there for folks that maybe a peer is no longer the appropriate level of care? So maybe we'll start with Michelle and then have Sonia speak to that as well. And Lisa, also in your experience around the training, what that looks like and how you balance the risks and rewards.
For us, the biggest risk is, yes, knowing the scope or recognizing when I need to ensure that that higher level of care isn't implemented. And we really feel strongly in the supervision piece of it. And that's why we make the peers a part of our team. They attend all of the training. We offer, in our model, we offer extensive training beyond what they get with their peer support training and then their maternal mental health training, in addition to trauma work. But then we're in constant communication within our clinic with our peers. So that's, I think, essential in providing responsible care, because we don't want we don't want a peer to get in over her head and then have a tragedy or anything else come along with that. The rewards are, so in our area, we do have a lot of perinatal mental health certified therapists where we're really excited about that. Unfortunately, many of them don't accept insurance. And so we're one of the few organizations that our therapists all go through the perinatal mental health training, and then we'll be taking the tests for that. And we do accept insurance and bill the Medicaid plan. So in the process, in getting into a therapist, our peers step in and they bridge the gap. And they teach skills, they normalize the experience, and a mom doesn't have to wait 4 weeks, 6 weeks, 8 weeks to get in to see someone. Our peers will see someone within 2 days when they call. And that's unheard of. Or they'll see them bedside, which is even more exciting, right? So I think the rewards are that we can use them to meet moms where they're at when they reach out.
I want to say that this issue around the risk is something that we've been grappling with as we're building out our curriculum and our model for this pilot in the Inland Empire. And we've been talking very specifically about, one, that the opportunities for referring out, are a challenge. And so when we have women that are at a place where they need, either some direct treatment, like a psychiatrist, where they may need medication. We're trying to build a network of referrals, and that is a risk because you don't want to raise the expectations of someone that you can help them find care, and then you're dealing with this same issue that they're facing when they make the calls that they're unable to find care. So the Perinatal Mental Health Alliance, People of Color Alliance, is trying to build this database, around the country for professionals. But what we're finding is that we may have to embed a telehealth model into our program because there are people that we can reach by phone, and some have said, like, I will maintain a phone relationship for the program, but some of them are not here in California, and some of them are not located in the area where the women live. And so we're trying to think through what that looks like, as long as you have somebody to call, but they're liability concerns. And for us, the other risk is that when we can't reach someone, and we try to do our work in pairs. So we train women to mobilize in the community, and then they will work in pairs. So if you can't reach one, you can reach the other, or they'll show up together and work with we don't call them clients, but a sister. And so, you know, when you can't reach someone, we're even like concerned or risk about the risk of advising people of what to do. So the whole thing I mentioned before about dialing 911 and calling for help. And, you know, the feedback that we've received is that, you know, many women have experienced the loss of their children, the children that they already have, or the loss of, you know, sometimes in even a very aggravated situation when they call 911. I mean, I don't know, you know, how much you all know about this, but, you know, in the Black community, calling the police can sometimes result in your death. I mean, I'll just, you know, make it clear. And then anything before your death, you know, which is, you know, obviously, you know, extreme aggravation, potentially child services engagement, and then ending up in a institution. And we use the criminal justice system as a mental health provider in the state of California, in Los Angeles County in particular. So those are some of the risks that we really face, and we wonder about, you know, how do we, you know, we're standing in the gap, but we can't fill it completely, you know. And then how do we line up a number of professionals who will be at the ready when they're called upon to at least maybe provide, you know, some higher level intervention by phone. So that's one of the challenges. The rewards are numerous. I mean, we see women who embrace this idea of, you know, this group model of care, coming together to be able to talk about the things that are challenging, and even finally realizing, like, I didn't recognize that as a mental health issue. I didn't realize that when I wake up in the middle of the night and I feel like somebody's stealing my baby, you know, I didn't realize it, and I run in to check on my twin daughters. You know, I did not think of that. You know, I just know that I'm startled and I'm sweating, and then the next day I'm tired and I keep thinking about it. And we talk about that, and we talk about intergenerational trauma. And so what this woman ultimately learned that I'm referring to is that her grandmother had an experience where her children were taken in the middle of the night. And so it was only talking that story out in a circle, and then she went back to talk to her family, and she learned. It may seem, you know, like, really, you know, but those are the things that are happening. And so people are living, you know, through, if you know about epigenetics and you know about, you know, this weathering that's happening, that you're living through the trauma, you know, even past generations, on top of the psychosocial stressors that, you know, we all deal with. In this room, all of us would deal with those things, the loss of a job, you know, the loss of a loved one, or a bad breakup, or, you know, but when you add, you know, these other layers of things, and, you know, the microaggressions you experience daily, you know, women come to these circles, and it's, right now we've trained about 325 women in the state of California, so Northern California around the state. And when you hear the testimonies, when you hear them, and you can go on our website and you can listen to some of them, you hear people talking about, like, how it has impacted them and their own experiences, and then how they now feel so equipped and ready to go out and to help and support another Black woman in the life that she's living, dealing with perinatal mental health issues, the ongoing mental health issues in her life, and those of her family and the community around her. So we talk about our circle. We say, I need the circle needs me, and the community needs the circle. The sister circle, that fictive kinship, that model of care and support and coming together, because that, for our culture, is how we connect. We are not an isolated people. We don't, that has, for us, that's more of a Western model of living. That's not the way we live. We cook together, live together, sew together, you know, pray together. There is an inordinate reliance on faith, and we do talk about that. You know, we're like, and somebody last night says, she told her friend, suck it up, buttercup, you know, you got things to do. And that stayed with me, because we always say, girl, you better get down on your knees, pray that away, and get up and get on with your life. But we know better. We know better, and we teach and we train women that faith is a supportive factor, but it's not the only one. And God created mental health professionals. So and we can use them.
You want to follow that, Lisa?
I don't know how I can follow that. But thinking back to your question about some of the risks, one of the things we heard about when we were talking to people who had gone through the training was if you're fortunate enough to get a job in a place like WHI or, where there are those supports and the clinical oversight, and that's a wonderful thing, but not everybody who went through the training landed that either in the short term or who knows, maybe it just wasn't. They ended up not working in that kind of environment, and yet the training, because it was focused on maternal mental health issues, did raise some issues, and there was sort of a little bit of feedback, well, now what, and what if this raised all this awareness of these issues, and I have no support now. So that's definitely something that we've talked about as building that into future trainings, of having some, whether it's availability of a check-in or giving people resources. It's certainly, a concern. Yeah, absolutely.
And with that, so in Phoenix, we have several peers that were not placed, right? And we have the work for them. It's just then figuring out, as we've heard all the last 2 days, the payment. And because we are in one hospital system already, and we've had another hospital system approach us on this as well, and we can bring our peers in for that, which would be amazing. We constantly stay in contact with those peers about how can we expand upon this, because it's so needed. So hopefully we'll be moving in that direction.
And then this is a little bit of a pivot, but when Sonia was talking about having the telemedicine, that one thing about with the pilot training on pilot testing of the training, the original peer support training was a 2-week dedicated in-person, live training, and for a lot of moms with young children, that just wasn't very practical, and so they developed, a specific maternal mental health component that was distance learning, and I think that was really a big success. And the way it was implemented was also really ingenious, where you had somebody in the live training who could sort of build the bridge between the people who were doing it by distance and what was going on in the room. So I think that was an important lesson learned.
I don't think I'm telling tales out of school, but sometimes providers get threatened or there's friction around scopes of practice and bringing new providers into a field. So can we talk a little bit about if you've experienced any friction in introducing peer support into the community, and how you've been able to mitigate that, or work with provider groups around how we're all stronger together? Hassana, have you personally experienced any friction with other mental health providers or folks in the healthcare profession around being a peer and being out there in the community working with other women?
No, because I'm very independent. That's it.
Sonia? We'll just leave it at that.
I wish I could say that. But that's not always, that doesn't always work. So in our community, thank God, there is a light that's shining bright on doula care. And not bringing back, but even elevating, the care that midwives provide. And so we have seen some challenges in certain systems where, and we've seen this even across racial and ethnic lines. So I'm talking about even African American, clinicians who who have some challenges, with seeing either a doula or a midwife come in and provide, support for a Black birthing person. And so there's a lot of, in LA County and the Inland Empire right now, there is a growth of interest and understanding about the care that doulas can provide. And since many hospitals are now being made aware of that they are part of the issue around African American maternal and infant mortality, and that they have a role to play in that, and it's being highlighted, now there's beginning to be more conversations that say, well, let's see what we can do. And if a woman who doesn't feel comfortable sort of going to prenatal care, in certain settings, or goes and finds that 11 minutes is just not enough. Is it 11 or 7 or 12? Whatever. Somebody said 4. Not enough time, for you to get what you need. Then yes, the hospitals can now recognize that having a doula in the life of that mother can aid in bringing that mother to a birthing scenario where she's better equipped in that environment. She's also more knowledgeable to ask questions and to engage in her treatment and not be, sometimes people say, intimidated by what's happening in the clinical setting. So having a midwife there, now building relationships with the hospital systems, I think is going to help to address that issue. Because this scope of care, right now, there isn't enough that's going on to support Black mothers or Black, women in the perinatal space. There isn't enough. So in the meantime, until the systems can build the capacity to provide more care, and they probably won't, they probably need to just incorporate and embed doula care and midwife care into their models of care for, and I say specifically for Black women, until we reduce that disparity in such a way. And I do suggest often bifurcating the experiences of Black women in a hospital or in a clinical setting, because the disparities are so great that your traditional models of care are not going to reduce that gap, and have not for 40 years. And historically, we know in our community that midwives and doulas have, birthed our babies for generations, for hundreds of years, and we didn't see the mortality rate that we're seeing now, and that we see in third world countries.
I was going to ask a couple other folks to answer that question, but I want to make sure that we get questions from here and from folks that are watching across the country. So I think we have a few minutes for those, if I'm correct. And do we have a mic, or do you want people to pass questions? Okay.
Hi, you all are my heroes, Shiros. I love what you do. I do peer support. I'm a full-time volunteer. So I know you all touched on it a little bit, but with hopefully the peer support specialist becoming maternal mental health and billing, is that in group settings as well? Is that intended? Because for me, leading groups where I'm privileged enough to be able to do it without a fee, there are people that can't afford weekly just the meetings. That doesn't include prep time and debriefing time and being on Facebook and managing a group and talking to moms or going to their house or all of that. And is there a part of that that is intended for payment? Because people can't do this for free, and we can't expect these moms to keep, we've hit the max of asking these women to keep volunteering their time, but how do they get paid?
I'm really glad you brought that up. I was hoping payment was going to come up, so let's go there.
On that one.
Michelle, do you want to talk first about payment? Yeah.
So we most of our staff has volunteered a large amount of their time as well, and so we in particular changed our licensing of our facility so that we can bill for our peers, and it takes like an act of God and your DNA to get credentialed with some of the Medicaid plans in our state. However, we're in the process, but in the meantime, we've been able to get prior authorizations for our peers, and we have gotten paid for our peers, whether they've been on-site or off-site. And I mean, that takes a lot. So if you can get into a system, and that's what we want to do. We want to create a system like this that can go out into the communities and make this happen. We know it's working, and we're making a difference. So we need to make it happen now, because we can't expect our peers to continue to give our times, or else we'll be all flat on our face saying, okay, I'm fine, I'm fine, I'm fine.
Are there online training modules for perinatal peers that can be accessed outside of these programs, particularly ones for Latinas? And then somewhat related, for the project, Lisa, that you mentioned, what kind of supervision was provided?
I can talk about the Latina one. I would definitely get in contact with the folks that developed Alma. Again, their contact information should be in the app, because it is an online Spanish, completely in Spanish, for Spanish-speaking women and individuals. And so I think that would be a good resource for you. And then I forget the rest of the question, but it was Lisa.
So the question was about supervision. So we, like I said, we provided online contact and then group contact with the peers as they went through their training. Our initial group that went to the 2-week in-person experience had something come up that was not, it was because of the vast array of differences amongst the peers. There was a pretty traumatic event that came up. So then I provided the supervision to debrief that event as well. And our organization provided continual contact to the peers. But then we brought on peers as our employees. So then they were provided that.
Well, I just wanted to offer support. I ran a peer program for over 10 years in California, and there's actually quite a bit of funding through MHSA funding, Mental Health Services Act funding, and specialty mental health definitely covers peer support. So I also worked with law enforcement. I developed a crisis intervention training for peers, as well as a mental health crisis call brochure that's been published throughout California. So if anybody wants information about peer support in California, I'm happy to speak to that.
My question's for Lisa. Really in the terms of research and evidence-based practice and what you would suggest. I'm here for Secure Beginnings. We currently have a parent care program where we have volunteers going into the homes up to 4 hours a week during that perinatal period. And so I'm really interested in how we can get more efficacy and how we can find those partnerships for research, especially for grants and funding.
There's definitely work in this area in the scientific literature. So you might want to start there by just seeing what's out there that's relevant to your work. And I know SAMHSA supports a lot of They have grants around recovery support that may not be specifically about maternal mental health, but they would certainly apply.
In Arizona, one of the organizations that works primarily with peer supports just received a SAMHSA grant to train peers as doulas. And then they're going to provide the maternal mental health. We're going to do the maternal mental health part of their training. And so it's for the SMI population and substance using population, which is amazing because that added support is invaluable. So there's a lot of work going on in that.
There's a suggestion that we also continue this conversation on the app, especially people that are sharing resources because it's so rich. I'm going to go here.
Hello, thank you for all of your comments. I've been working with the Department of Public Health here around the Office of Violence Prevention, around a peer initiative, cross-sector, not particularly mental health or maternal mental health. And one issue that has become quite concerning to us is that we see most supervision of peers is done by licensed mental health in a mental health model, whether it's social work or as an MFT or whatever it is, not in a peer model. And there is significant difference between a peer model and a mental health model. And I'm wondering, how are you addressing this and not turning peers into mini clinicians? To which to say is they don't have the training for it, and so it puts them in a very precarious position and it diminishes what is their big skill, which is the lived experience.
That's an excellent question. I don't know who wants to take it first, and then I can share a little bit about, they've been struggling with that in Colorado too, as they develop this Latina model. Where is the right anchor, right? Where is the right hub and the right home for peer support specialists so that it isn't actually a part of the mental health system in Colorado, but it really is of and for and by the community. And so I do think there is a lot. This is a perpetual question of what's the right connection point and what's the right space to make sure that you do have that touch point back to expanded care if you need it, but also respecting the program for what it is and what its real benefits are. So Hassana, please.
I think that individuals should seek out maybe independent peers or independent doulas that have the lived experience that is best fitting their situation. I think that would be a great help, because otherwise it's like altered when you're dealing through the mental health or, the other organizations. Your best bet is to look independently for independent peer or doula.
That is an interesting dynamic, because one of the things that we focus on is that our model is very PEI focused and prevention and early intervention focused, and that we're training women through this sister circle model, and the sister circles continue. So once the women complete the training, then they operate a sister circle that's ongoing and existing in the community. And the reason why we are not yet pursuing any certified training, even though we know that there isn't a standard model for California as of yet, but is because we want to be careful not to, mix up, sort of like the provision of mental health care. And the way we're addressing that is that's why we focus on the pipeline work of trying to increase diversity in the professions, encouraging people to, add perinatal mental health training as a part of their, their existing competencies, using the, telehealth models or ways to get the training, through other sources, and even training doulas, to have the knowledge and experience around mental health, to recognize that, and even midwives. Historically, you can operate from the space of lived experience, but you cannot attempt to stand in the gap as a mental health provider. And we are so serious about that, because as the women doing this work, we already have enough burdens. We can't take on now, something that could potentially even be a liability issue for us, and not to mention a guilt issue and those things, because you can't be a replacement. You're just in the gap, and assisting and navigating someone to get the higher level of care if they need that.
Time. Oh, I knew we were going to run out of time, but thank you everyone very much, and thank you to the panel. It was wonderful.
Yesterday, we heard powerful stories that touch our hearts and inspire us to do more. Our next storyteller is Kelly Cummings McGrady. She is a registered nurse and enrolled member of the 3 affiliated tribes, Mandan, Hidatsa, and Arikara, also a lineage of Seminole of Oklahoma and Lakota Sioux of South Dakota. She's married and a mother of 5 beautiful children. Kelly is currently a fellow of the Robert Wood Johnson Clinical Scholars Program and serves the 3 affiliated tribe and Elwood's Memorial Health Center's Native Youth Suicide Prevention, Building Resilience, Building Health program. Let us welcome to the stage Kelly Cummings McGrady.
Good day, Sigids. Miana Woods heads, Kelly McGrady heads. Good morning, my name is First Woman Kelly McGrady. I greeted you in my father's language, which was forbidden, which is Hidatsa. And like Apple said, I'm Mandan, Arikara, Hidatsa, Seminole, and Lakota Sioux. I am the Ika, mom of 5 beautiful children, and one which is with me today, Kale. I would like to say Mazgrads, thank you for this awesome opportunity to be with a caliber, a phenomenal set of people, professionals that are doing such amazing work. And when I look at all of you, I'm in awe to say that there are such resources that I would love to tap into. I am part of 2% of the millions of Indigenous people that were annihilated, exterminated, decimated, and put genocide by the US government. Currently, I'm 0.8% of Indigenous population that is here in the lands that we call America today. My story is much like many other Native mothers in this nation among nations to experience elevated, off-the-charts, adverse childhood experiences. We have suffered historical trauma, complex trauma, chronic trauma, and at times acute trauma. I also exhibit survival and resilience. Looking back, I now understand that I had postpartum depression with all 5 of my children. I was a mother at 19 to my eldest son, Kelson. He's now 23. Shortly thereafter, I went to active duty, and I became pregnant with my second, McKaylee, and she's 20. After she was born, my husband joined the military ranks himself, and he went away to training for a year, and then he went to Korea. So I was a single mother, didn't know what was happening. And it was ugly. I didn't have the social supports that I needed. At the age of 24, I had my 3rd child, Kale, and we were stationed in Fort Lee, Virginia. And that's when my world came crumbling down. All the traumas that I suffered came flooding back to me. It was awful. I didn't have the coping skills. I was admitted to Hopewell, Virginia, inpatient, the psychiatric unit for 3 days. There, I shared my story with some psychiatrists. There was 3 of them sitting there among other staff. I shared my story of being molested multiple times, of being drunk, blackout drunk at 5 years of age, that I was high on weed at 5 years of age, that my first suicide attempt was at 9 years of age, that I was abandoned, that I was neglected, that I was even beaten. When I told my story, these psychiatrists looked at me and they wondered, they said, "Is this the first time that you've ever been hospitalized? How did you do it?" My only answer was it was survival. This little girl in this picture, I'm the one in the pink, it was survival. I didn't know anything other than that. I didn't even realize that I'd faced so much adversity in my short life. I continued with outpatient therapies and treatments while my children's father went off to war. That's when, after the 9/11 happened, we were stationed out there with all of those stresses added on. So there I was, a mother of 3, a little baby. He was just tiny. I didn't know how to take care of him. But I was so thankful for mental health professionals like yourselves to teach me. I learned about art therapy. I learned about journaling. I learned about grounding. And some of those things brought me back to the strength of my ancestors. I still share a lot of those tips that I learned with the Native mothers on my own home reservation in Newtown, North Dakota, and the surrounding areas where we lack mental health services. We don't have one psychiatrist And actually, we've just brought telehealth into the Newtown Public Schools because they're inundated with adverse childhood experiences. We're inundated with Native youth suicide attempts. My hope and my dream is that we can end those health disparities for all people of color, that we can have that healthcare equity for everyone. And my hope and my dream and my prayer is that a lot of you in this building, in this room, will take your phenomenal resources that you have and share them with our people. We're often a forgotten people, an invisible people, to be only 0.8% of the millions of Americans. So as we sit here on this last day pondering the emerging considerations in maternal health and mental health, we can do more. Help me send the resources home to all the Indigenous reservations in America, because all of them are the same. No matter where you go, to Washington State or to Oregon or to Montana, to North Dakota, South Dakota, Minnesota, New Mexico, Arizona, Oklahoma, we need you. So I'd like to say Mazgrads, and I just wanted to share something on that resilience. If I can do it, other Native moms can do it as well. And I love the panel this morning when they talked about ladies of color or sisters of the or sisters circle. That is amazing. Keep it up. So just as we come into love of a mother and love of Valentine's Day for tomorrow, I just wanted to share something with you because my children are my strength. So I wrote this February 14th, 2013. To my Valentine's family, I love you all. I know I may expect a lot from you. I may be hard on you. I may think you can do better. Just know I love you, the whole universe deep. I live to see you smile, wish to save your hurts, promise to do my best. I will be less strict and more loving and kind when disappointment and hurt becomes a part of our lives. We only live once. Only one time will I be your mother. Know that I am you and you are me. One day will come a time when we will no longer see each other because of travels of distance or death. And then you and I will know I love you so. Love, Mom. Mazgrads.
My name is Katie Moss, and I am lucky to be the storytelling lead for 2020 Mom. And it's my honor to introduce our next speaker, Dr. Kara Zivin, who is a senior health researcher at Mathematica Policy Research. She's a professor of psychiatry, obstetrics and gynecology, and health management and policy at the University of Michigan. She studies the impact of health policies on health outcomes for perinatal women, older adults, and veterans with behavioral health conditions. Please join me in welcoming Kara.
Hi, good morning. I'm so glad to be here and to hear all the stories and to hear just about all the different experiences that we have here and to share our study with you that we conducted at Mathematica last year. And this came out in time for Maternal Mental Health Week last May. It's available publicly on the web. There's also printed copies at the California Healthcare Foundation table right outside here if you're interested. And it's been getting a lot of attention, so I'm really happy to be invited to be here. And in fact, I have really exciting news that the peer-reviewed publication that we wrote as a companion to this issue brief as part of our work was accepted for publication last week at the American Journal of Public Health. I'm really excited about that. And we had to do a pretty extensive revision to this piece because they wanted more details. I'm going to be showing you some data that we collected, and so I don't know exactly how it will turn out when the paper finally comes out in press, hopefully before the end of the year, this year of the mother. But it'll probably be another 12 pages worth of, fine-grained detail. So hopefully that will be useful for those of you who are interested in really wonky type of information of that sort. So going on from there, as I think I probably don't need to say to this audience, but I think, just as a, level setting of where we're coming from, maternal mental health conditions, as I'm defining it, using the term here, although I realize that the perinatal mood and anxiety disorders has snuck into a few slides, but by and large, we're calling this maternal mental health conditions, including primarily depression and anxiety, are very prevalent and common in the United States. And yet, over half of the women who experience this disorder do not get the treatment they need. So that's where we're starting from. So we were really interested, and through our funders, which I'll talk about in a moment, we're interested in the societal costs of untreated disorders. So this does not just include things like how much does it cost for a doctor's visit, but broader concepts. We really wanted to be sure that we thought about things like what happens when you either can't go to work or you go to work and you're not feeling very functional. What is the cost of that? Can we put a dollar amount on this to try to get the attention of policymakers, of insurers, of others to try and understand, the burden and the scope of this illness? So we created a mathematical model that quantifies these societal costs and puts them all together in a single model, and we specifically focused on the early years of a child's life. We were focused on both mother and child from conception to 5 years postpartum. And we did this intentionally because there are some studies that will focus on lifetime costs, and I do think that that is important to think about the long-term consequences of this illness. But at the same time, we recognize that many people have the same insurance for only, say, a year or two. Insurers are not necessarily interested in the costs that are going to accrue when your child is 18. And so that we really wanted to focus the time period of this model on the years surrounding birth. So we also wanted this model to be able to be publicly available, and so anybody can reach out and ask. I'm happy to send you the details of the model, and I'll talk later about some of the different sources, and I've even communicated with some people here in the room, I think, about it, so it's been exciting to see who's interested. And then we just also, so that you are aware, in addition to the work that we did with my research team on this project, we actually had a multi-stakeholder advisory group that advised us. We met with them 4 times over 9 months in a virtual webinar type format where we showed them at each step along the way what we were doing to include in this model. And because there are a lot of decisions to make about what goes in and what gets left out. You can't include everything, and so I'll talk about some of that as well. So basically what we did is we used what we call a cost of illness methodology to synthesize existing evidence. And so this is evidence that's either published through peer-reviewed medical literature or the gray literature online or other places, to try to gather a variety of different inputs into our model. And so the idea of this model was to try to understand what is the cost of not treating these conditions in the United States. Now, obviously, people might want to know how much it costs to treat, and that's a different question, but we wanted people to understand, if we did nothing, what is happening here compared to, women who do not experience these conditions. So as I mentioned, we looked at the first 5 years of a child's life. We did an extensive literature review, and we included 5 maternal and 9 child outcomes that I'm going to talk through here. So this may be a little bit hard to follow in a short amount of time, but I'm hoping at least the color coding can kind of guide you. Basically, we wanted to start with an actual conceptual framework and have some sort of ordering principles of what we thought this would look like. And so we wanted to include both costs and outcomes for women and children, and then look at how those led to 3 main areas of reduced economic output, of public sector costs, and to healthcare costs. So I've listed here the different outcomes that we explored in our model. And so, as I mentioned, these aren't just financial costs of healthcare, but things like productivity loss, maternal suicide, benefits, different types of financial public assistance benefits that women might receive. We also looked at child outcomes such as preterm birth, child injury, well child visits. So, a variety of different topics that may be of interest when thinking about these disorders. So the punchline is that for each mother, the cost of untreated maternal mental health conditions is $32,000 for the mother and child over a 6-year period. And so when you break that down into the cost for the mother and the cost for the child, it's $19,520 for each woman and $12,480 per child. And so more than half of these costs occur during the year that a woman delivers a baby, but then, the remainder extend through on the rest of the 5-year period. And we did this model using a 2017 cost. So when you add that all together, according to the number of births in the United States, we estimated $14 billion, like billion with a B, this disease costs per year in the United States. So it is a really big problem, and I also am going to continue to contextualize that because sometimes it's hard to take these numbers, well, compared to what, right? So, but first I wanted to highlight which costs we were talking about. And one of the things I found interesting through this work, because you don't know when you start how it's going to necessarily work out, that productivity losses were actually the highest costs. So for women, and so you might have thought, well, what about healthcare costs? And those were up there as well as C-sections, but yet those losses to employment were, a large contributor. And I think that maybe can make sense once you say it, but you don't necessarily think of it that way going in. And then in terms of child costs, preterm birth was the leading cost, then associated with child behavioral and developmental disorders. For again, these are younger children, so this isn't even including what happens as children get older, and then also child injury. So this is looking at the same information I just presented in a different way, so you can see the relative costs. And again, as you see, the productivity losses and the health expenditures really dominate the proportion of costs that are associated with this illness in mothers. And then here in children, again, preterm birth is an important contributor to the costs, as well as child behavioral disorders. So just something to think about in terms of the relative burden of these different components. So here, what we did was, any of these estimates that we used, it could be very easy for a critic to say, well, why did you pick this article, or why did you pick this number, and people could debate about which numbers you wanted to include. And so we did what's called a sensitivity analysis to see, well, if we changed the range of across the different articles that we read and information we had, what would we find? And as you can see, even though our model with the estimates we included had costs up to $14 billion. Here, depending on what you consider the prevalence of maternal mental health conditions to be, there are competing estimates. Sometimes you hear 1 in 7, sometimes you hear 1 in 5, sometimes you hear 1 in 11. That starts to frustrate me because it's like, well, what do we listen to? But anyway, we tried to include those various costs, and you could see it could be up to $60 billion a year. So, I mean, it really is, I think, a staggering societal burden. So again, to try to contextualize this a bit, we went back and forth with our expert panel, like, would we compare this to cancer? Do we compare it to heart disease? And people thought, well, no, that's probably not the best comparison, because we really wanted to stick to other delivering women in conditions that people might experience in and around pregnancy. And so we came up with trying to use postpartum hemorrhaging and gestational diabetes as comparisons, just because at least it's the same population, the same life period. And as you can see, maternal mental health conditions are both much more prevalent than those other conditions and much more costly. So I do want to be sure to point out model limitations. You know, as I mentioned at the outset, we had a specifically, focused time frame, which really just is another way of saying this is an underestimate of the lifetime burden of this illness if you consider the long-term, as we were talking about yesterday, the 2-generation issues associated here. We did not focus on the economic case for intervention, although I've been kind of trying to nudge various people that would be a really interesting study if anybody wants to see that done, especially, we have Sage Therapeutics here focusing on the new medication postpartum, which I think there should be an externally funded study for that, but I think it would be really important and interesting to compare that medication with inpatient stays, with electroconvulsive therapy, with various other different components that people could use to treat this disorder. Because even though there's some concern about the price tag for that medication, it's always compared to what. If the alternative is no treatment and you have all these long-term consequences, maybe that number doesn't look so bad. We don't question some other high-cost drugs for other conditions. But I'm going to try and avoid a soapbox here. But anyway, we did not do any primary data analysis. So by that I mean we did not go out and talk to women individually. We did not consult their, individual medical records, in part because we really wanted this model to have data that would be publicly available, and those records are considered private. We did not include non-maternal caregivers, and that was another big source of debate because, clearly fathers, partners, grandparents, other people have a role and also have costs associated with taking care of both the mother and the child who is involved in maternal mental health conditions. But due to scope creep, we really wanted to try to keep this model focused. But again, that's another area of costs that we probably aren't considering. We did not have the level of publicly available data that we had hoped to drill down to at a finer level on either geographic units or racial and ethnic disparities or those types of things. And we really wanted to only include estimates that we felt were really felt good about and felt were representative. I was also asked, since we're here in California, and California Healthcare Foundation was one of our funders, along with the Zoma Foundation and the Perigee Fund, to talk a little bit about our California-specific findings. So we actually have 4 issue briefs that are available. We have one that are national costs, and then we have one for each of those 3 states. And so here we, some of the numbers that we use are based on national estimates, but others we try to take account for things like the number of births in California. And so here actually we found that the maternal mental health conditions are higher than average, the US national average, and that here, and I'm having trouble seeing it, but almost 70,000 women in a given year in California experience these conditions. So just think of that. And they had similar top costs as our primary model, but here I just included the comparison we had to the US general population and then California in particular. And again, you can see the prevalence here is higher in California. It's over $2 billion just in this state associated with not treating these conditions. Slightly higher costs as well for maternal and child care. And then, slight differences in the ordering of the most expensive outcomes. So our takeaway points, we included this number of the 1 in 7 women, and that was actually not from our study. That's one of the numbers that is included in a lot of publicly available material. I would argue it's closer to 1 in 5 and even more like 1 in 4 in certain subpopulations. But our findings really were that $14 billion for not treating this disorder in a given year, and that's an underestimate. And remember that more than half women do not get treated. So, so as I mentioned, we have these 4 issue briefs. I will show in a minute my email that people can reach out to me so I can send you more details if you want, and our forthcoming paper. Few quick reflections here at the end. So, the U.S. Preventive Services Task Force could implement more maternal mental health screenings and provide treatment if indicated. this would have benefits for women's health, their children's lives. It would improve societal productivity and decrease use of social services. So I personally hate having to make an economic argument of why we should treat this condition. I think we should treat it because we should just do that as a society. But for some people, they are more moved by these economic arguments, and so I think you can, effectively make that argument. And stakeholders can support not just screening. Screening is not enough because, as we know, just identifying that someone has this disorder does not necessarily connect them to relevant treatment, and that's really what we need is access to care, quality of care, and affordable care. So I wanted to share, as I mentioned, we put out these issue briefs last May, so we're about 9 months into them being out in the world. And I still, actually, even in the last week or two, I get people emailing me, asking me, saying, hey, I'd like to see about what would the cost be in Georgia? What would they be in Montana? From public health agencies, universities, the March of Dimes, a variety of different people. And then actually I was really excited. So I live in Michigan now, and our governor cited our report in her State of the State address last week, where she was talking about trying to extend Medicaid coverage from 60 days to 1 year postpartum. And at the bottom of this document that said healthy babies and moms, she cited our issue brief. So and I didn't send it to her. So it's interesting that this is out there. People are learning about this information, and it seems to fill a gap that we had in the knowledge about this disorder. I show here, and we can circle back to this if you want, just the members of the advisory group that we had. It was really great to work with, researchers, economists, health providers, pediatrician, OBGYN. It was just a really great mix of input on thinking about this model, and I think it lent it some credibility. This wasn't just stuff that we made up in my research group, but that, we got a lot of input from others. So this is just, I wanted to acknowledge both my project team and the funders for this work. It was so exciting when they put out this statement for proposals. I personally am really committed to this work, and so I just had to do this project, and so I'm really excited how well it's turned out, and I think they've been pleased as well. I also wanted to, this is the hard part of this talk for me always, that this is very personal for me. This is my son. He turns 9 next week. And when I was pregnant with him, I was very severely ill. I tried to commit suicide by overdose when I was 8 months pregnant. He was a preterm birth. He went to the NICU, and I went to the psych ward. And I am extremely fortunate that I survived and that he survived. And I have basically tried to spend my time since then trying to do this work. It's actually his birthday next week, which means that it's the anniversary of my overdose next week too. And so it's, but I'm here, and I'm trying to, I guess this disease knows no boundaries in terms of race and class and income. I saw both of my OB and my psychiatrist less than 48 hours before I took a lot of pills. So I can just tell you that this is real and it's important, and I'm so glad to be here and share this work, this data with you, but also the personal component. So for more information, here is my contact information as well as each of the funders and the link for the issue brief. And I'm happy to answer questions now or later. And thank you very much for your time and attention.
First of all, thank you so much for giving us a price tag. It's important with the work we do with Mom Congress, going to politicians. We needed this a lot. My question is there a way for you to create the cost per state and make that available? Because this would help in Florida.
No,
and
I
I'm
would
sure
love
everywhere.
it too. And that part of what I've been doing is sending it to people with instructions on how to do it yourself, because I don't personally have the resources. So hint, hint, if anybody would like to support us doing this for every state, we've thought about, could we make a dashboard? Could we,
and I hate being up here talking about money, but, this project ended, and so unfortunately we've had to move forward. But I would really love to see that, because I think there is so much variation, and there's so many different other avenues that we could take. But in the short term, I'm happy to send along, and that's what I've been doing when people ask, well, hey, I want to do this in, Georgia or South Dakota or whatever. But yes, it is feasible to do, I would say, for other states. It's, again, harder at more like the county level, but at least at the state level, I think we could do it.
Hi, thank you so much. I'm Harvey Karp, pediatrician. One of the questions I had is that the London School of Economics did a study on the cost of postnatal depression, and it came out to a number of about $9 billion for the total costs of postnatal depression. So it seems like it's quite a bit higher than the 2017 California study and the one that you put together here. And one of the obvious issues is that stopping at 5 years, because obviously the problem doesn't stop at 5 years. What was the thinking in going into that and trying to I'm just concerned people are going to hang on to this number as if this is the right number. Yeah.
So actually, Annette Bauer, who was the author of the London study, was on our advisory panel, and we specifically sought her out because that was one of the few data sources that we had prior to this work, and we still communicate with her. To me, very honestly, I would ask the funders are the ones who suggested to us we really want to focus on this time period. And as I said, it's my understanding, and I don't know if they're here in the room right now to answer, but I believe that, again, it was because we know that people switch insurance so often that if we were trying to make lifetime projections, it would really, people may not be as interested, in worrying about, okay, this costs this now, but, you're talking about 20 years from now. And yet I completely take your point. That people sees numbers, and so there's no perfect answer. We've tried really hard to be really clear. This is what is included. This is what is not. This is an underestimate, but I recognize that message can get lost sometimes. So I would just say that it's imperfect, but I don't. Again, I'm happy to do another study where we extend it out. If you want to do that, we can try that too. Yes.
I'm trying not to fangirl out knowing Harvey Karp is in the room because you saved my family. So I just had a quick question on your percentages for the number of pregnancies and deliveries with diagnosis. Did that include postpartum diagnosis, post-delivery diagnosis?
It's a good question, and I have to go, but we have like 100 different data sources, so I have to double check. I believe that our prevalence numbers were based on the PRAM study, so the Pregnancy Risk Assessment System, which is not, I'm missaying the acronym right now, but the CDC funded work, so that is where we got that, but also. And again, we were using prevalence estimates as opposed to claims-based diagnosis files, if that makes sense. And we were also pulling these out of the literature as opposed to, again, running a study and checking. So it's another imperfection of this type of work, which is another reason why we did the sensitivity analysis. But because we also did cover the post-delivery period, it should include that as well. And actually, PRAMS, now as I'm thinking about it, because I have other studies in this area, you're asking people to reflect backwards on what happened during pregnancy, but you can also incorporate postpartum.
Thank you so much for this work. We've talked in the past, and it's been really wonderful to see this brought into California. I know that when I read the report, I was a little bit confused about the 2.4 billion and what that what the assumption underlying that was. And could you share with the group, because I don't want to misstate it, does that assume that none of the diagnosis or none of the prevalence was treated, or is that among currently in California the percentage of women who have maternal mental health conditions who are not receiving treatment? So what is the assumption there?
Sure, I know, and it gets complicated because we can't always know from the
estimates in the literature what % of women did actually get treatment and how effective was the treatment and how long and what was it and, you know, all of those different components. So I think it is a valuable question of how that all came together, and I feel like I'm not going to do it justice. I feel like you always have had really great specific questions about how we actually came to all of these various numbers, which was essentially adding up, okay, you know, here's a prevalence of this in this study, and here's the cost, so, you know, prevalence of SIDS, or here's, you know, suicide. So I think I'm trying to figure out how best to answer it, and I may need to punt for now, but I guess the point is that what we did not do is take, you know, a bunch of women that, okay, here are all these people, we know for sure they don't have a diagnosis and they're not treated, and here's a bunch of people, they're treated, this is what they're, you know, we were basically saying, okay, what would happen in all of these different instances of, you know, what would be the productivity loss if you had this disorder but you didn't go to work across a population, and the same thing for all of the different estimates, but I realize I'm not giving a very satisfying answer, but the good news is that it will all be in great detail in our published paper, which hopefully will come out this year. So, but I'm happy to try to talk with you one-on-one to try to make sure I answer it better. Thank you again.
Well, thank you, Dr. Zivin, for your presentation and that incredible and important work. And as we've heard from Maureen and others, that it's being put to use in really important ways. So we appreciate it. We're excited now to talk a little bit about policy, federal policy and the state policy landscape. And I have the pleasure of inviting Katrina Velasquez to the stage with me. She's the principal of Center Road Solutions based in DC, and has really joined the 2020 MOM team to help us vet federal policy opportunities and to support much of the work that's happening with Mom Congress, which there are flyers on each of your tables to learn more about that policy opportunity and how we gather women to be the voices for policy impacting moms in DC together. So I'm going to start. We wanted to start by just giving everyone the frame around what's happening with the trade associations, so the professional societies, and where have they landed around screening, for example, of these disorders. We want to always start with and acknowledge the leadership and the vision that the American Academy of Pediatrics has had in this space, really recommending screening before all of the other associations did so. And I think that was reflected in the conversation yesterday, right? That pediatricians really have sort of a heart for acknowledging the struggles of mothers. And they were the first to recommend screening in their Bright Futures recommendations, and they ask, how are you feeling? The American College of Obstetrics and Gynecology, ACOG, recommends screening at least once, and that came out in, does that say 2015? There's a poll, 2015. Most recently, some of you have followed the great work from another task force at ACOG that just recently published in 2018 a recommendation that OBGYNs reconsider the postpartum period, and it's called the 4th trimester. So it doesn't specifically address screening, but it acknowledges that perhaps we should be seeing mothers beyond one appointment at 6 weeks or 2 appointments if there's a cesarean. And so we just really want to applaud ACOG for acknowledging that there's more work to do, particularly in the postpartum period. After ACOG came out with their recommendation, the American Medical Association followed suit, the larger association for all MDs, including family physicians and others who should be screening, and recommended screening for these disorders as well. So you also might have heard about the U.S. Preventive Services Task Force, and there's been a couple of positions on maternal mental health that have come out recently from the task force, which we're all really thrilled about. Again, because of ACOG's leadership in reassessing their position, which previously, I should have noted, was to not recommend screening. They specifically excluded, they excluded it was the U.S. Preventive Services Task Force that specifically excluded pregnant women from their recommendation to screen adults. It wasn't ACOG, it was the U.S. Preventive Services Task Force. But when ACOG came out and overturned their position to recommend screening, that there was enough evidence to recommend screening, the U.S. Preventive Services Task Force followed suit and now recommends that screening happen in the perinatal period. We also had another report out or recommendation from the U.S. Preventive Services Task Force in 2018. That was an exciting year. And Aline Barrère, Dr. Barrère is in the room, and some of her research and the work that she does was referenced in this position. So in addition to recommending screening, the U.S. Preventive Services Task Force now recommends screening for those who are at high risk and intervention around maternal depression. And so what those recommendations mean when the task force comes out is that insurance companies need to pay for these services on a preventive basis under the Affordable Care Act at no charge. So what we also know, though, is just because all of these organizations are saying it's important doesn't necessarily mean it gets put into practice, right? And that's the next statement here, that the Agency for Health Research and Quality, AHRQ, has reported in 2019 that only 35% of all adults have been screened for depression using 2015 data. And we know also, is it 17 years, researchers in the room? The AHRQ says it takes for a clinical practice guideline to be widely adopted. So that is too long for moms, right? Okay, so a little bit about the Affordable Care Act, just to get your bearings. What does the ACA require around maternal mental health or any of these services? And it basically, the Affordable Care Act says that individual and small group health plans, so a lot of you may be covered on individual and small group employer plans, that benefits are considered EHB. Large group plans need to cover those EHB essential health benefits too. And I'm not seeing that slide so well. And there can be no lifetime dollars or visit limits on essential health benefits. There is a second point there that talks about, again, coverage for screening because of the U.S. Preventive Services Task Force. What we wanted to point out, though, there was a lot of excitement around the ACA passing and, oh, good, now people will get screening for these disorders because of the U.S. Preventive Services Task Force recommendation. But insurers were already covering screening. The problem is that they weren't being screened. Women weren't being screened. And so it changed the copay to $0 copay because it's a preventive service for all plans, PPOs and HMOs, but previously HMOs already covered preventive services at $0. So a lot of technicalities there, but the ACA didn't do that much for us is the point. We have to increase screening rates organically through the provider community. Federal mental health parity, we're not going to go into this really at all because I think all of you heard the panel yesterday. You can quickly look through these points if you'd like, and also know that these slides will be up in the app. And so other federal policies, some of you may remember the Melanie Blocker-Stokes Act. And this is when Brooke Shields actually went to Congress and testified on behalf of this important legislation. It recommended and recognized the life of an African-American mother who died in Chicago, and I won't go into the details, but it was very visual and a compelling story. And it suggested that the National Institutes for Mental Health consider additional research and that the Health and Human Services Agency provide additional grants when funding was available. The interesting thing was that this bill passed, but there was never any additional funding. There was never an appropriations ask that followed suit. So it was beautiful to raise awareness, but really didn't effectuate change in the end. What we hear from our partners at the NIMH, though, is that we don't really need additional funding. We know what the solutions are. We just need to implement them. So they actually said it was a good thing that there wasn't additional funding provided because that wasn't necessary. And so the most recent bill that was passed in 2015 or introduced in 2015 was HR 3032, bringing postpartum depression out of the Shadows Act, which many of you in the room were involved in heading to the Hill to advocate for the passage of this bill. It came out of the Massachusetts MCPAT for Moms model and was carried by a congresswoman there in Massachusetts who loved what the state of Massachusetts was doing around telepsychiatry consultation. So increasing access to OBGYNs and others who are screening for these disorders and developing treatment plans, helping them have a lifeline to a psychiatrist to vet difficult cases with. And she said, I think other states should be doing this work, and I want to provide grants, federal grants to states who are interested in developing those consultation programs. And I'll talk to you in just a minute about which states received those grants and how many received them. And just most recently, and I'm going to turn it over to Katrina here in just a moment, there was a federal interagency task force effort that 2020 Mom helped to lead, which was very exciting, that we're going to have Katrina talk about. So here are the states, briefly, before we talk more about that task force that received the grants, 7 grants around telepsychiatry consultation. You can see them up on the screen. We have learned recently that one of our sister nonprofits is doing some work to extend funding, reauthorize funding essentially to provide more grants in this space to other states. All right, Katrina.
All right, so looking at 2020 Mom's most recent initiative, so we began working with Joy and her team in April to really see what we can do to help the agencies work together in the federal government around maternal mental health. And so what we decided to work on was the appropriations process for this. We were a little bit behind the appropriations deadline, so we were throwing some Hail Marys left and right. We were able to get a touchdown, which was so exciting for all of us. But really what this effort was looking at was creating a temporary interagency task force for the agencies to evaluate what they're currently doing for maternal mental health and where those gaps actually exist and report those to Congress. And so it sounds like, well, we know where the gaps exist. I'm like, I think everyone here probably knows very well where the exact gaps exist. The agencies and Congress, not so much. And so that's why this report is so important, because it pretty much gives us a launching off point on where we can go for future policy making on the federal government side of things. So looking at who led this, the same Congresswoman who led Bringing Postpartum Depression Out of the Shadows Act, Congresswoman Clark, she was the main lead on this appropriations request. And then we had a couple of other senators who jumped in along the way to really push it on the Senate side. So we had Senator Durbin from Illinois and Senator Baldwin from Wisconsin really taking the lead on this. So just kind of looking at process-wise, so Clark was able to get this within the House report for appropriations. The Senate, if you guys follow policy at all, there was no report. And so what we were happy to find in the end was that in the end passage in December, this language was actually included and passed into law on December 20th. Also, we had a lot of great maternal health and maternal mental health and mental health organizations supporting this. So we had a big support letter going around in the summer period where we had over 60 organizations supporting this language, which really helped to get us over the finish line there. Looking at what this is going to be in the end, so it involves a variety of different HHS offices to participate in this, including the Surgeon General, HRSA, the Office of Women's Health, SAMHSA, and many more. What they'll be doing is working together to identify what they're doing right now and those gaps, and they'll be submitting the report to Congress come the end of May, June time period. So of course, 2020 Moms will let you know really what the next steps are from there, but we hope this will really lay the groundwork to continue pushing policymaking on the federal side.
I think we should celebrate.
Yeah. Yeah. So, one thing I want to go to is really before we talk about what I expect this year, I often get the question of what actually happens during election season, right? So I think there are some who are like, a lot can happen, and some who are like, a little can happen. Well, I actually personally love election season. And so the reason is because it actually puts a time frame on Congress to do something. And so, the rule of thumb as you're thinking about federal policy making is that politics, policy, procedure. Politics always wins, and then there's policy, and then procedures. Can you actually make it happen? So this year, quite a lot can actually happen. It's just really in a condensed time period. And so typically what we see during election year is, you'll laugh at my acronym here, I call them Save My Seat priorities. And so these are really for kind of those vulnerable members of Congress and senators who are trying to get that last win in before it comes to really election campaign route season. So you'll see a lot of initiatives being put out and really a push from many vulnerable members of Congress and senators. The NDAA almost always gets passed even in election season. If you've been paying attention at all last year, this NDAA actually included federal parental leave in it. So parental leave available for federal workers. So there's a lot of good things that you can attach to the NDAA. Funding the government. The last thing you want to do if you're in election season is to have the government shut down. So funding the government, the appropriations ask almost always get passed during election season, which you can attach other things to it. And then there's always small stuff, resolutions, things like that happen. Time frame, when to look for it. Really right before elections. So we like to see Congress like to do things right before they go home for that August recess period where they're really campaigning a lot. So I expect, and we'll talk about it in a second, that there'll be a pretty big authorizing package that'll be passed, I expect in May, but maybe even June time period. And then sometimes when we see the chambers, meaning the House or the Senate, when they flip, or if they flip, or if the administration changes, we'll see a lame duck period that's actually pretty active, where the parties that are still in power will try to get kind of some of those last initiatives done. So kind of looking at what I expect will actually pass this year, there could be a variety of things. Like election year is very exciting because things that you don't necessarily expect can happen. But the one thing that I do for sure expect to pass is the lower healthcare cost package. So this has so much stuff in it, but the things that are most important for everyone here are really these maternal health pieces, which some of them actually loop in maternal mental health items. So you'll see a lot of grants here, so grants for maternal care, quality and outcomes. There's trainings for healthcare providers in a lot of maternity care aspects. I think a lot of these trainings can easily be looped into maternal mental health if you are someone who applies for state and local grants. Perinatal Quality Collaborative. I think the most important things up here are the rural care. So there's going to be obstetric network grants, data collection, and most importantly, demonstration training grants that also in the actual language do include maternal mental health training. So that's a really important one for everyone to keep an eye on. And then the telehealth network, so there's more grants that I think can be related to what you guys are all doing here today. And then finally, there's one provision going back to the parity piece where they're strengthening parity a lot more on that compliance side. So having payers doing a lot of more comparative analysis reporting and then giving Department of Labor that power to actually fact check them, so to speak. So these are things that I expect will likely pass in, I would say, end of May in the extenders package, or if that gets extended, maybe that June, July time period.
So we wanted to also let you know that we're tracking, not through the 2020 Mom website and brand, but through the Mom Congress website and brand. So if you haven't checked out Mom Congress yet, you can go there. It's mom-congress.com. But Katrina and her team are helping us track all of the legislative priorities and asks. There are, I think we counted over 60 maternal health bills in going through Congress as we speak. And so we're tracking all of those bills, and our member organizations have access to that list too, our Mom Congress member organizations. And we will provide updates on all of these things through the Mom Congress blog and e-newsletter. So if you're interested in more than maternal mental health, but maternal health, including maternal mental health, Mom Congress is the place to go for that information. A couple of the bills that I thought would be helpful to share with you. One was mentioned yesterday, the Violence Against Women's Act, and this is a reauthorization that responds to the nation's crisis of domestic violence, dating violence, sexual assault, and stalking. So a lot of interest in this reauthorization. There's more information that you can find online. We'll do a blog post, I think, about this on Mom Congress, but somebody did ask, do we think this is going to help with maternal mental health? And I think the answer is, yes. The story that we heard yesterday was a testament to the struggle that women have once they become mothers or become pregnant after a sexual assault, for example. The Family Act, which is being led by one of our nonprofit partners here in the room, is a federal paid family leave bill. There are several other paid family leave bills that we'll be tracking as well. The Helping Mamas Act, a couple of folks have referenced state policy around extending Medicaid to 12 months. California passed some legislation as a result of one of the maternal mental health bills that will allow Medicaid to be extended in California this year for 12 months, but it's a continual budget ask. And so whether or not it'll be beyond 1 year, we don't know yet. But this is also being addressed at a national level. And I can't remember what state, Colorado, somebody mentioned it earlier, is also looking at federal policy. Illinois, who was that? Somebody just mentioned it this morning. So other states are starting to dapple with this, but that's the Helping Mamas Act that 2020 Mom Congress have been instrumental in getting behind. So in terms of maternal mental health, I already had mentioned that likely to be a bill introduction or a reauthorization of funding around bringing postpartum depression out of the Shadows Act, so providing additional grants to states, and that effort will be led by, I think our partners are watching online, the nonprofit organization led by Adrienne Griffin, the Maternal Mental Health, I'm drawing a blank, Leadership Alliance, thank you. I always want to say liaison group, but that's another group. And then we're also looking, 2020 Mom is really looking at potential funding opportunities for states to provide grants to hospitals who are interested in developing outpatient and inpatient maternal mental health programs. We all heard Stephen's story and the amazing work that he did and fundraised and put his blood, sweat, and tears into creating an outpatient center in Pennsylvania. But we also know that we don't have Stevens in every community, and we need Stevens. So we believe that this is a really important federal budget ask. So more to come on that. And I wanted to talk just a little bit about some state policy opportunities as well. So, I can see that the lineup there looks funny. That should say state advocacy. A resolution, for creating a maternal mental health task force. So California was one of the recent states that passed a resolution, it was in 2015 actually, to call for the formation of a multi-stakeholder task force, similar to what the state agencies are doing now at a federal level, but at a state level and including private organizations and nonprofits. So A1, who was here yesterday and did a breakout session that is the nursing, obstetrics, and women's health nurses, was at the table at this task force. The Hospital Association, the Insurance Trade Associations, and others were represented. And that resolution called for private funders in California to fund the effort to create this task force on maternal mental health. And of course, Stephanie Tlecki in the room has really become the superstar in California in this space for investing in work like this. It was also invested in by the California Endowment. We're here in one of their buildings in Los Angeles, but they funded this work in California as well. The report was issued from that task force, which was basically what's happening in maternal mental health nationally and in our state and what needs to be done. And it really became known as the state strategic plan. And some even said, really, this strategic plan for the nation, because much of what was recommended in that report was not unique to California. And you can see that report on the right was our follow-up report. And so very wisely, that task force recognized that it was important to track whether the recommendations in that strategic plan were being implemented. And there were recommendations for all of the stakeholder groups, not just state agencies, et cetera, but organizations like breastfeeding coalitions and organizations like A1 were asked to take specific action, and ACOG, the American College of Obstetrics and Gynecology. And so we followed up with them to make sure they received the recommendations for their organization and asked them what they did. So the end game in that strategic plan was, again, the task force was very wise to say we should set a goal. How do we know if it's working? And they said we want to see 100% of women screened by the year 2025, right? That it's important. It's not always achievable, right, or probably ever achievable to get to 100%, but we think we need to say that. And we want to see in the intermediate space 80% of women screened by the year 2021. So what year is it now? 2020. This report was issued to the state legislature and to the public, and we'll talk about what happened once the report was issued. I also did want to call out, though, that the report did something that other reports hadn't done before, and it was we talk about the fact that no one federal agency or even state agency has addressed maternal mental health directly, right, because it doesn't fit cleanly under one agency's purview. And that, of course, has been the case with women and doctors saying, well, it's not quite me, it's not an OB's issue, it's more a psychiatrist, or pediatricians saying, yeah, well, I can do a little bit, but I'm not the patient's doctor. So it doesn't fit cleanly, right, in any one provider type. But this report acknowledged the important role of obstetric providers. This says OBGYNs, but it's really obstetric providers in screening, always screening for maternal mental health disorders, but also recognizing that there should be no wrong door. So meet mom where she is in all settings. And that was identified in part because we know so many women are headed into pregnancy with an untreated depression or anxiety, and that new onset is almost as frequent in pregnancy as in the postpartum period. And of course, the cost for preterm birth, et cetera, is important. So what came out of that report? And I'm going to ask Kelly Kay, who's in the room from Maternal Mental Health Now, to stand up. Kelly, where are you? Are you here? Did you step out? So Maternal Mental Health Now was a critical partner. Once that report was issued, we had legislators saying, what can we do? We know we want to fill some of these gaps. And so we joined forces and invited Maternal Mental Health Now to work alongside us to draft these policies and work on implementation. Many of you know California passed a screening mandate that requires obstetric providers to screen for maternal mental health disorders at least once, in alignment with the ACOG recommendation to screen at least once. It also, that bill, 2193, also required insurers to put programs in place to address maternal mental health. It initially, that language said insurers create case management programs so that obstetric providers and mothers have support once a treatment plan is developed at finding in-network care, et cetera. And the sausage-making process, through that process, that piece got peeled out, but is being looked at being reintroduced this year in California. AB 3032 is hospital maternal mental health. It asks hospitals to create programs to train all the clinicians in their hospital that work in their hospital, and to inform mothers about the range of disorders, signs, and symptoms. It doesn't require hospitals to screen. And again, you might have questions like, well, why didn't it ask OBs to do the education around patients, and again, sausage making, but really excited about where this landed. And the last piece I want to say about that bill that we're really excited about is that hospitals have to provide information about local treatment options, if any. And what we're learning and already hearing is that hospitals are finding there are no treatment options and getting inspired to develop their own, even if it's a support group with a trained clinician and peer that are providing support groups, for example. And then one final bill that passed this last session is around having the state medical board create training materials around maternal mental health for MDs. So possible pending legislation this session, this next week is the bill deadline in California, but we have definitely secured an author for introduction of what we call, well, I'm going to start with the top bill, not the bottom. So it was, someone mentioned MHSA dollars in California. Prop 63 was a proposition that taxed millionaires, 1%. That goes back into community mental health programs. And we have long been wanting to tap into those resources, including early intervention dollars here in California. And we are now doing that with two bills. One is asking counties to report what, if any, of those dollars are being used to address maternal mental health. It doesn't require that they address maternal mental health, but we want to know what county departments of mental health are already doing something around maternal mental health. That data is not being reported anywhere now. And then the second bill is the consultation program, so modeled again after Massachusetts, utilizing, creating a centralized maternal mental health and child psychiatric consultation program. So a centralized program that will be a piloted program that will also tap into MHSA Prop 63 dollars and enroll up to 5 counties to start to pilot that program. And then the last thing that we wanted to mention is that there's a lot of interest now that California's legislature understands maternal mental health for a number of years now, has been well educated, that it might be time now to talk about the hard topic of mothers who've been put in prison because of infanticide and untreated maternal mental illness. And Illinois has recently passed, just 2 years ago, a law that asked for cases to be reevaluated of those women to see if sentencing could be reduced. And so that is really a topic that we're very interested in addressing this year in California. And then finally, the other states. What are other states doing? This is a quick map. You can't read this, I know, but it's in the app. And you can see which states are taking action on a variety of issues. We do also want to say just this week in Arizona, 3 bills were introduced, one including a task force, the formation of a task force to create a state strategic plan using the California model. A lot of that work's being championed by the March of Dimes, who also worked on and sat on our task force here in California. So resources, what can we do in our states, and what resources can we refer to? So we wanted to let folks know that 2020 Mom is launching a state policy learning network, and we're inviting 4 states to join us in that learning network this year. The program will be launching shortly. We have the 4 states in mind, but if any state is really interested, we'd love to talk to you. And then finally, we want to remind folks that this report is called The State of the State, Maternal Mental Health in California and Beyond. And it really provides a landscape review of all of the work that's happened in the United States and California between 2017 and 2019. It was published in December, and so we encourage you to take a look at that to see what work is left. Thank you, Harvey.